We're going over the whole second guide from exercise physiology, which I believe is everything on the cardiovascular system, how the heart adapts to exercise, and then I think it hits training adaptations, VO2 max, and I'm not sure if he hits cardiovascular of risk factors for heart disease, but in case I'll cover that also. But since he hasn't posted a study guide because it's too far in advance, I have my study guide, and I'll go over my questions, which are probably the same exact questions because he very rarely changes it. And I'm pretty sure you all have my study guide anyways because the study guide that was sent out was a lot of my questions on the study guide that someone else made from last semester. With a little, I mean, they obviously didn't use everything I had, but they changed a few things, but it's very similar, so I'm sure all of you have it right now. But essentially, you have to understand how the heart works. The main part of exercise physiology is how the heart and the cardiovascular system adapt to exercise, because that's the main thing that adapts to cardiovascular exercise. And that's the point of this major. So first you have to understand the heart before you even understand how it adapts. So a simple overview is you have the heart, it's on your left side of your chest. It has, just imagine a four-chambered box. And there's two upper chambers and two lower chambers. The upper chambers are called the atria, or atriums. The lower chambers are called the ventricles. So you have the right side and the left side. So now the whole cardiovascular system is blood going through the heart, being pumped out the heart, going through arteries, capillaries, veins, and going back into the heart, and thus repeating the process, just to exchange oxygen and pick up waste products and everything. So since it's a closed loop, which means whatever blood is pumped out of the heart is what is returned to the heart. You don't lose blood at any point of the circulation, or you should not lose blood. And a healthy individual will just pick part of the loop. So we'll pick the right atrium, which is considered the starting point in most books. They consider the right atrium, even though of course there's no starting point. But the right atrium, or the right atrium and the right ventricle on the right side of the veins, it's all deoxygenated blood because as we see when it pumps out through the arteries, it's oxygenated. But we'll go to the right atrium, it's deoxygenated, it's returning back from the body after it gave all of its oxygen to different parts, different tissues. So enters the right atrium deoxygenated, it returns to the right atrium via the superior vena cava and the inferior vena cava, which are the largest veins in the body. And these are carrying deoxygenated blood from the upper part of the body and the lower part of the body. So the superior and inferior vena cava return deoxygenated blood to the hearts, to the right atrium. And then once in the right atrium, it all falls into the right atrium, that one box, and then it falls down to the right ventricle, directly underneath it, going through the tricuspid valve, which is a little valve separating the boxes. And then this valve is important when you think that, okay, if it can fall down the box, it can easily go back up the box, and you don't want blood regurgitating going backwards, which should be going to the ventricles. So that little tricuspid valve, that valve is like a door. Once all the blood falls into the ventricle, it closes and keeps the blood in the ventricles. So now in the right ventricle, it pumps out to the lungs. And so it goes to the lungs, it's going out the pulmonary artery, going to the lungs. And when it gets pumped to the lungs, it's still deoxygenated, it doesn't have oxygen. That's the point. That's why it's going to the lungs and it's going out the pulmonary artery. Now, the pulmonary artery is the only artery in the body that carries deoxygenated blood, so that's one exception you have to memorize. So it carries it to the pulmonary artery, goes to the lungs, and the lungs it gets oxygenated, picks up all the oxygen that we breathe with every breath, and then goes into the pulmonary vein and goes into the left atrium. And the left atrium, just like the right atrium, there's a door called the bicuspid valve or the mitral valve. You have to know both of those names. It's always called the mitral valve, but he likes to call it bicuspid valve to confuse you. So it goes out down the mitral valve, the bicuspid valve, into the left ventricle. In the left ventricle, it gets pumped out the aorta through the arteries. And then the aorta pumps it throughout the whole body. Now, since the right ventricle is only pumping into the lungs, versus the left ventricle pumping it throughout the whole body, the left ventricle is huge. It's massive, it's much stronger than the right ventricle. And I can guarantee you that will be a question knowing how does the left ventricle differ from the right ventricle? Well, the left ventricle pumps blood throughout the whole body. It's oxygenated and it's much bigger, much stronger, has a lot more muscle than the right ventricle because it's pumping it through a much larger pressure differences and pumping it throughout the whole body. So it has to be much stronger. So those are the differences. And that's just a simple review of how the heart functions. It's a loop that happens every single heartbeat. Yes. So that was just a review of how the heart functions. Now the first question is, what are the expected training effects from aerobic exercise on heart rate, stroke volume, and Q, which is cardiac output, also seen abbreviated as CO or Q. Mean the same thing. Again, they love to do that in physiology, have the same exact terms that mean the same exact thing. So heart rate is simple, just how fast your heart beats every single minute, or how many times your heart beats. You can easily measure it just by putting your hand on your wrist, very easy. Stroke volume means how much blood the left ventricle pumps out with every single beat. So obviously, the greater this number is, the more blood you're getting to your body. So it makes sense to have a larger number. And cardiac output is how much blood circulates your whole system every minute. So thus, a higher cardiac output means more blood every minute. Thus, it's better. So now, what are these better training effects? The easiest way to do anything about expected effects is you have to do a comparison before they train and someone after they train. So take someone at rest, they're just sitting here like I am, and they're out of shape, they haven't trained. Most likely their heart rate is 70 to 80 beats per minute, and their stroke volume is a certain number. Let's pick 110, which is the normal stroke volume. So 110, 70 to 80 beats per minute. To get cardiac output, or Q, you multiply heart rate times stroke volume. Since heart rate is how much times it beats per minute, stroke volume is how much blood it ejects with every single beat, it makes sense that you multiply those two numbers to get how much blood circulates or how much blood your heart pumps every minute. So you get a certain value, which will always be between 5 liters per minute or 6 liters per minute. And this is a set number, and we'll go over that in a second, why it's 5 to 6 liters per minute for men, and if they're untrained or if they're trained. So that's an unfit athlete. You take a fit athlete and rest, and now their heart rate is going to be much lower. Why would their heart rate be much lower? It'll be much lower not because their heart's weaker or it beats less, it's less active. It'll be much lower because their heart is so much stronger from aerobic exercise that it doesn't have to beat as much to supply the same amount of blood throughout the body. If you think of the heart as a muscle, every time it beats, it takes energy. So it makes sense, it's productive for the heart if it has to beat less, so it uses less energy. So the more in shape you are, the less it has to beat, the less energy it uses, but since it's beating less, its stroke volume, or how much blood it pumps every minute, is higher. So if you just think the heart as a muscle, when you work out, your muscles get bigger, they get stronger, they get more effective at doing their job. So the heart, same thing as you work out with aerobic exercise and cardiovascular exercise, your heart gets better at doing its job. So it gets better at pumping blood throughout the body. It pumps more blood with every single beat. So now that 110 stroke volume, every heartbeat is now probably 170, or probably not 170, 130 at rest. But since it's pumping so much more blood, it doesn't have to pump as much, because you take a fit individual and an unfit individual at rest, their body is still their body. It still has the same amount of muscle, or different amount of muscles, but it's doing the same thing. It doesn't need more blood. It doesn't have any reason to have a higher cardiac output at rest. So that is why between a fit athlete and an unfit athlete, their cardiac output is the same exact thing at rest, because their body doesn't require more blood, because the muscles don't require more blood. They're doing the same thing. But the heart rate is lower because it's more efficient, so it doesn't have to beat as much. But the stroke volume is higher. So you can think about the concepts, or you can just look at the formula. Cardiac output equals heart rate times stroke volume. If the heart rate is lower and the cardiac output is the same, then the stroke volume must be higher. Just look at proportions. So that's at rest. Now you take, I believe, the normal cardiac output at rest is, or for unfit athletes, like 15 or 20 liters per minute when they're exercising and maximal exercise. But I'll get that later. Okay, so now we take when they're exercising. You take a fit athlete when they start exercising. Obviously, we know our heart rate's going to increase, so it's going to beat faster. And as it beats faster, our stroke volume also increases because our body has a greater demand for exercise. Our muscles need more blood, so it's going to pump more blood out. Your heart adapts to anything. So if you need more blood, it's going to pump more blood. So it does this until you reach your max heart rate, and then you get a certain. So the formula equals your cardiac output, which is probably 15 to 20 liters per minute if you're unfit. Now you take a fit athlete, and when they start exercising, obviously their heart rate increases, but it increases much slower. The reason being because your heart is much stronger, so it doesn't have to beat as hard to maintain the same exact intensity of exercise. But their stroke volume increases substantially compared to the unfit exercise. So whereas the unfit person had a stroke volume of 110, and then say at max exercise, the stroke volume is like 130 or 140, 150. The fit athlete has a stroke volume of 130 at rest because the heart's much stronger, but then at maximum exercise, the stroke volume might be 180 or 190 milliliters per minute per beat. Reason being because the heart is much stronger, so it can pump out much more blood with every single beat. And as a result, their cardiac output is much greater when you're fit. Some of the world-class athletes have a cardiac output of like 30 to 35 liters per minute. And the greater this is, the more efficient your body is at exercise because you can pump much more blood with every single minute. And obviously, more blood equals your muscles can function for a lot longer, and that's good. So the main difference between a fit athlete and an unfit athlete is the heart rate. A fit athlete has a lower heart rate at rest because their heart is much stronger. It doesn't have to beat as much, but their stroke volume is much higher at rest compared to the unfit athlete. And then when you start exercising, the fit athlete has a much higher cardiac output. The heart rate increases slower at the same intensities because it doesn't beat as much. Everyone knows this from personal experience. The more in shape you are, the slower your heart beats at the same intensity. Your max heart rate does not change with rest. Your max heart rate is the maximal your heart can ever beat during exercise. That's not going to change because that is dependent on age. As you grow older, your heart unfortunately gets less efficient, gets weaker. And the formula is 220 minus your age to get your max heart rate, your estimated max heart rate. So like my estimated max heart rate will be 220 minus 23, so 197. Now that's an estimate based on everyone in my population. My max heart rate might be 205, but you can't tell based on the formula. The formula is just an estimate. But no amount of training will ever increase your max heart rate beyond your true max heart rate, if that makes sense. So you can never increase your max heart rate. Okay, that's about it for that question. Question 2 is how electrical impulses pass through the heart. What are the physiological events associated with the beat of the heart? Again, you already know the anatomy of the heart. The electrical impulses is essentially from anatomy 1. Everything you do in the body, every movement, every breath, every heartbeat, every time you contract your muscles, everything is due to electrical activity. That's what the nervous system is. The nervous system activates by action potentials, which are electrical activity. So the heart, every time it beats, it has an action potential go from its right atrium all the way down to its left ventricle so it can contract the muscle. Everything happens through electricity. So that's the electrical stimulation of the heart. Now, unlike every other organ or every other muscle, everything else in the body, the heart is not dependent on the nervous system or doesn't depend on the body. The heart is considered autonomic or autorhythmic, which means the heart doesn't need stimulation from anything to beat. The heart has it's called the pacemaker of the heart, which means it doesn't need stimulation from the brain or from the body or from the nerves. It just beats by itself. So that's why if someone has heart surgery and the heart is outside their body, obviously they're unconscious and the heart's not in their body anymore, but the heart is still beating. Obviously the heart's going to die because it doesn't have a blood supply, but the heart can still beat. So the heart can beat without stimulation from the rest of the body. And that's the autorhythmicity of the heart, or whatever you want to call it. And this starts with the SA node. The SA node is the main pacemaker of the heart. And the SA node is in the top of the right atrium. And it beats by every 60 to 100 beats per minute, or it beats every 60 to 100 times per minute. So regardless of what is going on with the body, it's going to beat by the SA node is going to beat 60 to 100 beats per minute, whether it's outside the body or it's inside the body. It's always going to beat by itself. Now, that doesn't mean the SA node is the only pacemaker of the heart. The heart has many other pacemakers, which means if the SA node fails for some reason, then another node of the heart can take over and the heart can still beat. Because if the SA node was the only pacemaker of the heart, then if the SA node failed for some reason, you'll be dead. The heart wouldn't be able to beat. Now, the body wouldn't do that. The body always has backup mechanisms on backup on backup on backup. So it always has things to beat. But the SA node is the main pacemaker because it beats the fastest, 60 to 100 beats per minute. So we take electrical stimulation on the SA node. Now the SA node is in the right atrium, and we know blood pumps out the left atrium, the left ventricle. So the signal has to get from the right atrium somehow down to the left ventricle. In order to do this, it goes through different bundles and different nerves to slowly travel down to the left ventricle. And you have to know this pathway. This is the electrical pathway of the heart. So it starts in the right atrium, and then to get to the left atrium, it goes through something called the Bachmann's bundle, which I don't think you need to know. But to go down towards the left ventricle, it travels down a path and stops at this little thing called the AV node. And the AV node is like in the middle of the heart. So it traveled down slowly, contracted. Now the right atrium contracted, and blood went down to the right ventricle. Now at the AV node, it stops for a little bit, stops the signal. The reason it stops the signal is because blood passively falls into the right ventricle. It just passively falls when that tricuspid valve opens, so it can just fall into the right ventricle. Now, it just falls passively. But once the signal travels, like right here, the right atrium contracts and pushes whatever blood is left in the atrium down to the ventricle. And that's why the signal stops right here. So whatever blood is left can fall into the ventricle. So this pause is beneficial, so blood can continue falling into the ventricle. Now, once all the blood falls, the signal at the AV node now can move and it goes down the bundle of His, and that's just a branch way to go to so the signal can now spread to the ventricles. So it goes down the bundle of His, travels down the bundle branches, and then it splits into the right bundle branch and the left bundle branch, just like a fork in the road. The signal splits between these two pathways. Now the right bundle branch then just spreads to the right ventricle, causes the right ventricle now to contract because the electrical stimulation went through the right ventricle, but it also travels down to the left ventricle and causes the left ventricle to contract. Now at the end of these bundle branches, it splits even more because now the back of the heart has to contract. This is all looking at the frontal plane of the heart, or the frontal view of the anterior view of the heart, but now the back of the heart, posterior, has to contract. So it splits into little tiny fibers called Purkinje fibers and wraps around the heart, or the signal wraps around the heart, and it causes the back of the heart to contract. So this is the electrical stimulation, and then the signal just fizzes off and dies at the end of the Purkinje fibers, and then that's one whole heartbeat. And then it continues again, goes from the SA node to the AV node, stops a little bit, go down the bundle branches, or the bundle of His, splits into the right bundle branch, left bundle branch, Purkinje fibers, and then it just keeps continuing. The physiological events are the right atrium contracts, or the atriums contract when the signal travels from the SA node to the AV node, travels down the bundle branches, the ventricles contract. So the signal causes the contractions. Remember, everything happens through electrical stimulations in the body. And then blah blah blah, just explains it. Okay, SA node main pacemaker of the heart, determines heartbeat because it beats 160 to 100 beats per minute. Let's see, blah, 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 blah. Oh yeah. An easy way to think about it is think of the heart as one giant muscle. So as part of the heart contracts one cell, all the cells contract. That's why we have these branches to send the electrical stimulus. If that makes sense. But SA node, blah blah blah. Yeah, that's about it. Okay, question 3, understanding relationships and rest during submaximal and maximal. And it gives you 4 formulas. First formula is cardiac output equals heart rate times stroke volume. Second formula is the Fick equation. Or B and C are really the same equation, they're just changed around. So we'll go with C, that's the Fick equation for VO2. And D is also, he says the cardiac output equals peripheral P, which is pressure difference, divided by R, which is total peripheral resistance. But it's this formula isn't usually for cardiac output. This formula is usually used to find, well, in this case in the class, it was used to find cardiac output. And now I'm going to go into detail of everything what I said, so don't worry that didn't make sense. So equation A is the formula of cardiac output, already gone over really. Heart rate times stroke volume. Heart rate's in beats per minute. How many times your heart beats per minute? Stroke volume is in milliliters per beat. So how many milliliters are ejected per each beat? And cardiac output is liters per minute, or milliliters per minute. It's usually given in liters per minute. There's normally 5 to 6 for anyone at rest. Unless you have a heart condition, for some reason your heart can't beat as strong at rest. And then the values that change are heart rate times stroke volume, we all know this. Okay, now, during submaximal and maximal, this is an important difference. I am sure you'll ask a question. Now, when you first start exercising, as we know, your cardiac output, your heart rate increases and your stroke volume increases. But you have to know which one increases first. When you first start exercising, your heart rate, you can feel your heart rate increasing, but your stroke volume is what supplies the greatest increase in cardiac output, because your cardiac output increases while you're exercising linearly. It'll always increase. It never decreases. But your stroke volume is what supplies the greatest increase at submaximal exercise. So first, your stroke volume increases greatly. Your heart rate still increases, but eventually your heart rate is going to reach like a steady state. But your stroke volume just increases like this. Until you get to a certain percentage of your max heart rate, which I have 50 to 60%, but he uses 40%, I heard. But whatever percentage he uses, go with. But your stroke volume increases pretty good, pretty well, until it reaches that certain percentage. We'll go with 40% for this. It's 40% of your VO2. They always measure it in your percentage of VO2. But your stroke volume will increase pretty good until 40% of your VO2, and then it will level off. Because now your heart, as we find out when we get to Y, your stroke volume increases, has stretched as much as it can and pumped out, and it's reached its capacity for stretching. So it's pumping as much blood as it can every single beat. And now, once your stroke volume levels off, your cardiac output still increases with exercise. So now, what contributes that greatest increase? Heart rate. Your heart rate is the other part of the formula to get cardiac output. So now that your stroke volume leveled off at 40 or 50% of your VO2, now your heart rate is going to increase substantially. So now the little graph, you have a heart rate going like this, little guy, when you first start exercising. Your stroke volume is like this until it gets to 40%. But once it reaches 40%, your heart rate just skyrockets when you start exercising. And we all know this from personal experience. Of course, when you're unfit, it's kind of hard to tell this, but take a fit athlete or take a cross-country runner. I'm sure someone in this class runs cross-country. When you're in shape and you start running, your heart rate reaches a steady state, and your heart's really not working that hard. But obviously your cardiac output is increasing, so your stroke volume is increasing until you get to around 54, it changes the numbers a lot, but whatever number you use in class, 40 to 50% of your VO2. And after that, then your heart rate starts increasing substantially or exponentially. And we all know this feeling when you're running, your heart rate's increasing pretty fast once you reach past steady state. So heart rate will not contribute the greatest increase to heart rate to cardiac output. Stroke volume will. Heart rate will increase exponentially after it's cut off, whatever he gives. Stroke volume will increase greatly. So when you first exercise, stroke volume contributes the greatest increase to cardiac output. And then once you reach a certain percentage, stroke volume stops increasing, and then heart rate takes over. And we'll go why stroke volume increases in a few questions. Equation B is the same thing as equation C. If you're looking at it, it's just rearranging some values. So we'll go with equation C. Equation C is the formula for VO2 max. This is called the Fick equation. I'm sure this will be a question. This is a famous equation for exercise physiologists, the Fick equation, where VO2 max equals cardiac output times AV return. We already know what cardiac output is. Cardiac output is heart rate times stroke volume. So, and AV return is the difference between your arterial venous supply of oxygen versus your venous supply of oxygen. And we'll go over that in a second. Now, here's going to be a little tricky, and he'll probably ask, what is the Fick equation? It's simple question definition. And he'll give like heart rate times stroke volume for cardiac output. And another equation that doesn't even make sense. And then he'll give you VO2 max equals cardiac output times stroke volume. But he'll also give you VO2 max equals heart rate times stroke volume times AV return. Now, again, you can see that he just simplified one of them, did the same exact thing. They both are equal VO2 max. So VO2 max equals cardiac output times AV return. Now, VO2 max is the maximum amount of oxygen that your body, your cells can extract per minute. So that makes sense that your body obviously likes oxygen and needs more oxygen to exercise. So it makes sense that the higher this number is, the more oxygen you can extract every single minute. And you can extract more oxygen, you can exercise you have a greater, you can exercise a lot better. Your capacity for exercise is much greater, which is why all the elite athletes or elite runners and elite cross-country skiers and whatnot have very, 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 very high VO2 maxes because their body is very efficient at using oxygen. Because running out of oxygen is never a problem. There's always oxygen in the air you can breathe. That's not a problem. The problem is if your body doesn't use enough of that oxygen. And that's what exercise does. It teaches your body to use more oxygen. So VO2 max is a great measure of cardiovascular health, obviously. The greater VO2 you have, the more in shape you are, the more you can use oxygen. So that's good. AV return is the difference between the volumes of oxygen in the arteries minus volume of oxygen in the veins. Okay, so now to understand AV return, because that would probably be a question. It was a question when I had it. It's a hard concept to understand usually. You have an atrial supply of oxygen, goes to the capillaries, and then you have a venous supply of oxygen. Now, we'll pick a number, which the most common number he uses is 20. So 20 is the atrial supply of oxygen, which means you have around 20 milliliters per deciliter of blood of oxygen in your arteries. Okay, so you have 20. So say you have 20 milliliters in your arteries, diffused with or combined with all your blood and whatnot. Now it's traveling your body, and in the arteries, your arteries extract a certain amount of oxygen. So let's say 5. Your arteries extract 5 milliliters of oxygen. So what that means is now you have 15 left in the veins because you've only used 5. So you have 15. So your AV difference will be 20 minus 15 or 5. So your AV difference will be 5. Now say someone is exercising now, that's at rest. Say someone's exercising now and the body needs much more oxygen. If your body needs much more oxygen, it's going to take much more oxygen. So now you still have 20 because you still breathe in the same amount of oxygen. With a big misconception or a big myth is you get better at breathing, your lungs get better and can hold more oxygen when you're in shape. No, they can't. Your lungs, unless you have your lungs always go and breathe in the same amount of oxygen every single breath, unless you have a pulmonary issue or a pulmonary problem. But we're taking a healthy individual, so you're going to breathe again 20 milliliters of oxygen. Now your capillaries are going to say take 15 milliliters of oxygen because it needs much more oxygen. You're still going to have 5 liters left in your veins, but now the AV difference will be 20 minus 5, or it will be 15. So this will tell you that the higher your AV difference is, that's good. That a higher number insinuates that you're exercising, so that's why your body's using more oxygen. And plus, a higher AV difference will equal a higher VO2 by looking at the formula. Now that's mainly AV difference. So you have to understand a higher AV difference means your body is taking up much more oxygen. It's using much more oxygen. And that's a main factor in VO2 because the more oxygen you use, you never run out of oxygen with breath. Your body's never going to use 100% of its oxygen you have with every single breath. It's always going to keep some in reserve. But you'll get better when you exercise and your body needs more oxygen, so it's going to use more oxygen. That's what AV difference is. Question D is another formula to get cardiac output. It's Q equals P divided by R. P is pressure difference in the circulatory system. R is total peripheral resistance, and he'll have to give you that number. You can't. There's no way you can really tell R unless he gives it to you, or you have to calculate it based on. It's just a plug and chug. He'll give you numbers, and you have to calculate it. You just have to know the formula Q equals P divided by R and how to rearrange it by simple algebra. But Q, as we know, is cardiac output. P is pressure differences, so it's really delta P. R is total peripheral resistance, or pretty much the higher R is, that means the more resistant your body is at blood and blood flow through the circulatory system. So at rest, you have a high R, which means your body is pretty resistant to blood flowing through the system. But once you start exercising, R decreases because when you exercise, your body knows it needs more blood to its muscles, so it's going to decrease its resistance to blood flow. And it does this by vasodilating, which means the arteries get bigger. And as we know from take any tube, take a small straw and try to sift through it, it's very small, you're not going to get as much liquid. But if you take a big ass straw and you sift through it, you're going to get much more liquid. It's the same thing with the arteries. As it vasodilates, it gets bigger, it's much more efficient, it has less resistance to blood flow, so blood is going to flow, more blood is going to flow through the arteries. And this is what happens during exercise. Once you start exercising, your body senses this, and it's going to vasodilate the arteries, and the arteries will get bigger, and as they get bigger, you're going to have less resistance to blood flow. So simple, plug and chug. And another important thing you have to know is that blood pressure decreases throughout the body. It leaves the left atrium around 120 milliliters per mercury, and it slowly decreases as it goes throughout the body, and then it returns. And that's very important to know, that it slowly decreases as it goes throughout the body. And pressure differences is what drives blood flow throughout the body, also diffusion. Question 4 is what is blood flow redistribution and what tissues are affected? This is one of the most important concepts with exercise. The whole point of the heart, or the whole point of the cardiovascular center, which is in the brain, the whole point of exercise in the heart is to, when you start exercising, you have two needs. You have two simple things you have to fulfill. When you start exercising, your muscles need more blood. You need a higher blood flow in your muscles, and you have to control your blood pressure. So these are the two jobs of the heart and two jobs of the cardiovascular center, ultimately. To increase the blood flow to every active muscle in the body, or every active organ in the body, which is muscles. They need more blood flow when you exercise, and control blood pressure. You don't want your blood pressure to get too crazy high, because that's obviously not good. You'll die or blow something up. You want to control your blood flow, you want to increase your blood flow, and you want to keep your blood pressure in check. Those are the two goals of the heart. So, when you start exercising, all the arteries and capillaries, because capillaries are leading to the organs, but all the little capillaries and arteries that are leading to the muscles will vasodilate. They'll get wider. The reason they vasodilate is because you need more blood to the muscles, so it makes sense that they'll vasodilate and you'll get a greater blood flow to the muscles when you're exercising. Okay, so now again, before and after comparison. At rest, you take your total blood flow, or you take your total cardiac output, like 5 liters per minute. Where is that blood going at rest? Well, a small percentage of it is going to the muscles because your muscles don't need a lot of blood when you're resting. It doesn't have a need for it. So most of the blood is going to your GI tract, your digestive system, your kidneys, your brain, obviously. Most of the blood is going to other organs that are more active at rest than your muscles. But once you start, so the percentage of blood to your muscles is around like 20% or so, and all that blood is going to other places. But once you start exercising, that ratio completely shifts. You need much more blood to your muscles, so around 80% or 70 to 80% of the blood at exercise is now going to the muscles because it requires that greater blood flow. And since a greater percentage is going to your muscles, a smaller percentage is going to the less active organs. So your GI tract is not that active when you're exercising. Your liver, your small intestine, which is your GI tract, but your kidneys are not that active when they're exercising, so you don't need a great blood flow to these organs. So the blood is going to decrease at these less active organs and increase going to your muscles. Now, for the blood flow to your brain and to your heart, that's not going to decrease because why? If you're exercising, those are the most important organs, your brain and your heart. Why would you decrease blood flow to these organs? You just use common sense. Like, would your heart need your brain when you're exercising? Yes, it would. Otherwise, you would pass out. And that's why people pass out actually, is because the blood flow is decreasing in the brain. So your blood flow to your brain and your heart actually increases because you need more blood. But what is tricky is he does it in percentages. So when you're exercising, more percentage of blood is given to the muscles and less percentage is given to the less active organs. But your blood volume, how much blood you have in your body, actually increases when you exercise. So a less percentage of the maximal blood flow goes to your heart and your brain and your heart, but ultimately a greater volume goes to your brain and your heart. That's a little tricky thing that he can try trick you with. So in rest, most of the blood is shown as the liver, the GI tract, more active organs at rest, and not much is pumped to your muscles because at rest your muscles don't really need a lot of blood. But once you start exercising, majority of blood now, goes to your majority of blood now goes to your muscles because your brain senses that you're exercising, your muscles are contracting much faster. So it's like, oh, my muscles need more blood, so let me send more blood to my muscles. So more blood goes to your muscles, a lot more, around 70-80%. And the reason why is because your muscles need more blood in to dissipate more heat. More blood that goes to your muscles, heat travels in blood. So obviously when you're exercising, you create much more heat. Your body wants to get rid of that heat, so more blood will go to your muscles to dissipate more heat. It's more effective. Less blood is pumped to the organs not as important, such as liver, GI tract. Blood flow to the brain and heart will not change though. If anything, it will increase. Your brain, and your heart are important, very important. So when you're exercising, it makes sense. You still want blood to go to those organs. During exercise, the total blood volume will also increase, so you'll get more blood in your body actually during exercise. And also greater volume, so that means you have more blood circulating your body. Now, physiologically, why you're having more blood go to your muscles is that vasodilation and vasoconstriction, or changing the size of your arteries mostly changing the size of your arteries, making them smaller, making them wider. As we know, the radius of the arteries is the main determinant. If he gave you the formula, it's like your radius to the 4th power actually affects your blood flow. Viscosity affects blood flow. The more thick your blood is, that affects the flow. The length of your arteries affects the flow. If he gave all these formulas, all these reasons why, but also the radius. The radius through vasodilation and vasoconstriction is what affects blood flow the most. So at exercise, once you start exercising, all the arteries and veins and all the little tubes, that's not very scientific to say, but all the arteries and capillaries that are going to your muscles will vasodilate. They'll get bigger. They vasodilate because you want more blood flow ultimately to go to all your muscles. So they vasodilate. Now, whenever you have vasodilation somewhere in the body, you have vasoconstriction somewhere else. Remember, your body wants to control blood pressure. It has 2 goals: to increase blood flow, which it did by vasodilating, but also to control blood pressure. Now, if it vasodilated to muscles and didn't compensate by vasoconstricting anywhere else, your blood pressure, because whenever you vasodilate something, your pressure will decrease. Simple physics, whenever it has a larger surface area, your pressure decreases. So your pressure will decrease. So you don't want your blood pressure to decrease when you're exercising. So as you vasodilate to your muscles, you will vasoconstrict to your less active organs, such as your liver, your GI tract, your kidney, you vasoconstrict there, so you preserve that you preserve the blood pressure. Now, of course, your blood pressure is going to increase when you're exercising, but your body keeps that in check by constantly vasoconstricting and vasodilating. Yeah, vasoconstricting, vasodilating. So your brain is constantly working when you're exercising. So whenever you're exercising, you're constantly vasodilating somewhere else and vasoconstricting somewhere to keep your blood pressure in check, because you don't want your blood pressure to rise too much when you're exercising. Arteries vasodilate, arteries to the liver and GI tract vasoconstrict, so you keep your blood pressure in check. Now we'll talk about the auto distribution of blood later, so we won't hit it in this question. Now, what is the venous return and what factors influence venous return? Now, venous return is, since your veins return blood to your body, venous return means how much blood is returned to your right atrium. And also, since the circulatory system is a closed loop, if you return more blood to your right atrium, you pump out more blood in your left ventricle, closed loop. So you want to increase venous return, and that's what happens with exercise. With exercise, your venous return increases, and this is what increases your cardiac output the most, is venous return. So venous return is the amount of blood returned to the heart via the veins, and since it's a closed loop, more blood equals more blood pumped out. Venous return is actually what contributes to the greatest increase in cardiac output. Now, the things that affect venous return is obviously the blood volume. If you have more blood in your body, your body is more efficient at making blood, obviously you're going to have a greater venous return. Other things that affect that you have to know are muscle pump. Muscle pump means whenever any muscle contracts, your veins recoil and they pump more blood to the ventricles, which is why during exercise, one reason your cardiac output increases is because of the muscle pump. Your veins recoil, whatever, and they pump more blood. And this is also something that people can relate to, of why, for example, this is, take someone, everyone's had this situation where they're standing completely still for a very, very long amount of time. We take someone who's been in ROTC or someone's in the military. They stand at attention for a very long period of time, or they don't contract any of the muscles. Now, we all know when you stand at attention and if you stand still a very long period of time without moving any of your muscles, eventually you get lightheaded. And you get lightheaded because that muscle pump isn't working. You're not contracting any of your muscles, you're not moving anything, so blood is slowly, blood's still going back to the heart, obviously, because there's other factors, but blood is slowly, it's not as effective. You're not pumping as much blood back to the heart because you don't have that muscle pump. You're not utilizing it. Your muscles are not contracting, so eventually you get lightheaded. When you get lightheaded, whenever you get lightheaded, it's because you don't have enough blood flow to the brain, no matter what reason it is. And since you don't have that muscle pump going, you're slowly getting less blood flow to the brain. So that's one reason. So the muscle pump, veins are contracting, blah blah blah. Another factor is respiratory pump. Respiratory pump is the same thing as the muscle pump, but it's when you're breathing. So whenever you breathe, you inhale, you exhale, your veins contract and recoil. And another thing that is one-way valves of the vein, which means when blood is going to the vein, as you can see from gravity, blood is going throughout the arteries, but veins are going back to the heart through gravity. Gravity wants to push blood back. You don't want blood to go backwards, though. That's not good. So you have these little one-way valves, so when blood can't go backwards. So in a combination of the muscle pump, the respiratory pump, and the one-way valves, you accomplish blood going back to the heart. Because without a muscle pump or respiratory pump, blood will be going to the heart, and then these little valves will be closing, but pressure will be pushing them back. The gravity would be pushing back down, but you have this valve, so now blood is just stuck. But because the muscle pump, it'll pump it back up, and the respiratory pump will pump back up. So that's what increases venous return, and also greater blood volume and plasma volume. Now, 6 is describe the immediate adjustments made by the heart to allow for physical activity. Give the neural mechanisms of your humoral exercises mechanisms. Give changes from rest submaximal to heavy maximal. Heavy maximal just means maximal. I don't know why I said heavy maximal. So, as we know, with every heartbeat, our heart pumps out a certain volume of blood called the stroke volume. Now, since the left ventricle is the one that supplies blood to the systemic, this is the ventricle that we care about. Well, whenever they talk about anything about the effects of the heart with exercise, you're always looking at the left ventricle only. Because the left ventricle is what pumps blood throughout the body, so that's the one we care about. So when you first start, okay, so now this is the mechanism of why you increase your stroke volume when you start exercising. So you have your little box. it's pumping out a certain amount of blood, say 110 mil or 130, let's say you're in shape. So 130 milliliters of mercury at rest. Now the reason that your stroke volume increases at rest is because once you start exercising, your heart goes through this mechanism called the Frank-Starling mechanism. Now, the Frank-Starling mechanism doesn't depend on any neural mechanisms, no hormones. It just happens naturally. It's a passive mechanism. And what this mechanism says is, as your heart stretches more, it pumps out more blood. Now, what this means is, when you start exercising, you're obviously using more muscles, you're contracting more muscles, so your muscle pump increases, your respiratory pump increases because you're breathing more, so your venous return increases. Now, because your venous return increases, more blood returns to the right atrium. Goes to the right ventricle, pumps out the pulmonary artery, goes to the lung, gets oxygenated, goes in the left ventricle, the left atrium, pumps down the bicuspid valve, the mitral valve to the left ventricle. Now, the left ventricle, when more blood enters the left ventricle, it's a chamber, it's a little box, it stretches more and more and more. Now, just like the metaphor I give is a rubber band. Imagine a rubber band. The more you stretch a rubber band, the more it contracts, or the faster it contracts. With more, it has more contractility, it contracts much harder. Same thing with the heart. As the heart contracts more and more, not contracts more and more, as it stretches more and more, it gets bigger and bigger, and the bigger it gets with blood, the more it stretches, the faster it contracts. It's also just like any muscle. The more it stretches, the faster it contracts, the more forceful the contraction is. Now, as the contraction is more forceful, you pump out much more blood with every beat. So again, rubber band, you stretch it a little bit, and then you let it go, you fling it, it only goes like 2 feet. Not 2 feet, 2 inches, a little small distance. But you stretch it very far and let it go, it contracts much faster, and thus it's more forceful, so it pumps out more blood. So you can think of it as a toothpaste container also. If you push a lot of pressure on a toothpaste container, it pumps out a lot of toothpaste very fast. Whereas if you only push a little bit, it slowly pumps out toothpaste. And this is called the Frank-Starling mechanism. It's independent of everything else. It just depends on venous return. The more blood you return to the heart, the more blood that falls into the left ventricle, the more it stretches, the more it contracts, and thus the more your stroke volume increases. So that's the Frank-Starling mechanism. And now some terms that you need to know about it is, one term is EDV, or end-diastolic volume. End-diastolic volume just means how much blood enters the heart, the left ventricle. And since what we just said, more blood enters the left ventricle, the more it stretches. So the greater your EDV is, that means the more your heart stretches. So EDV is good. An increase in EDV is good. Another term you have to know is end-systolic volume. End-systolic volume is how much blood is left in the heart after it beats. So think of the lungs, the lung collapsing. A lung collapses because it has no air in it at all. So every time your heart beats, it pumps out a certain volume of blood, but it never pumps out all the blood completely. So your end-diastolic volume increases with exercise because the chamber stretches more, and more blood is falling into the left ventricle. So your end-diastolic volume is measured in milliliters, and that's how much blood is entering the left ventricle. Your end-systolic volume is how much blood is left in the left ventricle after contraction. So that means the greater your end-systolic volume is, the lower your stroke volume is because the less blood you pumped out. Now your end-systolic volume decreases a little bit with exercise because your heart stretches so much, it pumps out more forcibly, it pumps out all that blood. But you're never going to pump out 100% of your blood. You always going to have some blood left in your heart. So that's the Frank-Starling mechanism. More stretch, you have more contraction. But this also means that the Frank-Starling mechanism it doesn't just increase with exercise. Since that formula, or not the formula, but the values we went over, when you first start exercising, your stroke volume increases to about 40 to 50% of your VO2. And that's what happens with your stroke volume only increase. The Frank-Starling mechanism is only relevant, it's only active, it only matters until around 40 to 50%. And then your Frank-Starling mechanism stops working. That's why I'm sure you've all seen a graph where you have end-diastolic, it's like a little graph, you have end-diastolic volume right here, stroke volume right here. Your end-diastolic volume increases up here, and then it levels off. The reason being, and again going back to the rubber band example, is if you stretch a rubber band too much, it snaps, it breaks. And then obviously you can't contract it. Same thing with the heart. If you stretch the heart too much, it starts to be counterproductive, and the heart is not, your contraction decreases. So your heart can only stretch so much before it's counterproductive. So that's passive. Frank-Starling mechanism happens right when you start exercising. It just happens by increasing venous return. The other mechanism is, it's called the inotropic mechanism, which inotropic means it doesn't depend on anything else. It just increases the heart rate directly. So the Frank-Starling mechanism is passive, which means it indirectly increases your stroke volume. Its main purpose isn't to increase stroke volume, but it does because it just happens when you start exercising. Inotropic means it acts directly on your heart rate. Its only purpose is to increase your heart rate. And the example is with calcium. When you start exercising, this is through hormones, but when you start exercising, epinephrine and norepinephrine release more calcium, which we'll go over, but they release more calcium into the blood, which surrounds the heart. And as we know from muscle contraction, to contract muscles, you need calcium. So with more calcium, your muscles will contract, your contractility will increase, it'll increase your heart rate more, or to increase your stroke volume even more. Because more calcium means more actin-myosin bindings, so you need calcium to do muscle contraction. So the more calcium you have, it makes sense. The harder and the faster your heart will contract. So it'll be better, it'll be stronger. So more calcium equals stronger. Now the calcium is indirect to the Frank-Starling mechanism. They have nothing to do with each other. The Frank-Starling mechanism just happens because of exercise, just a side effect. But calcium, the inotropic effect is just its only purpose is to raise the heart rate. It has nothing to do with the Frank-Starling mechanism. Now, after the Frank-Starling mechanism happens and it reaches that plateau and it stretches as much as it can, eventually, that's when stroke volume starts reaching a plateau and it reaches its maximum number. Now, again, you can increase stroke volume with your fitness. The more fit you are, the more your stroke volume increases. But once your stroke volume eventually reaches a plateau, and once your stroke volume reaches a plateau, that's only around 40 to 50% of your VO2. That's not really, obviously, that's not maximal exercise, that's submax. So now to continue increasing your cardiac output so you can keep increasing your blood flow to your muscles, now your heart rate has to take over. And this is when your heart rate starts increasing substantially, or exponentially. I wouldn't say substantially, but exponentially. So your heart rate starts increasing. So now your stroke volume leveled off and now your heart rate is increasing. Okay, so now the mechanism to increase your heart rate. We'll go with the first mechanism of why at rest. So when you're resting, what causes your heart rate to be slow? I mean, we all know the SA node beats from 60 to 100 beats per minute at rest. But a lot of athletes have a heart rate lower, around 40 to 50 beats per minute. Reason being because the heart is more efficient and the heart's more efficient, so it doesn't have to beat as much. So the thing that causes your heart to beat less than 60 beats per minute is your vagal tone or your parasympathetic activity. If you remember, parasympathetic activity is rest and digest. So any body process or any thing that will decrease the amount of energy your body uses is through parasympathetic activity, rest and digest. Any mechanism that increases your heart's supply of energy is sympathetic or fight and flight. So anything that you think will help your body fight is sympathetic. Increase heart rate, increase contractility, cause your eyes to vasodilate, causes your bronchioles to vasodilate. Anything that increases your body, you sweat more, you're excited. Anything that increases your body, that causes your body to get ready to fight is sympathetic. So in rest, your parasympathetic is what's causing your heart rate to slow down. But once you start exercising, we all know our heart rate increases. But what happens specifically is, first your sympathetic tone decreases, it withdraws, it stops slowing down your heart rate until 100 beats per minute, until that SA node, because 60 to 100 beats per minute. So until 100 beats per minute, your parasympathetic activity withdraws. Then once it gets past 100 beats per minute, your sympathetic activity with epinephrine and norepinephrine takes over, and that's what causes your heart rate to increase even more. And it causes your contractility to increase and causes other things. So first, your withdrawal of the vagal tone, which is parasympathetic activity, causes your heart rate to increase to 100 beats per minute, and then sympathetic activity kicks in and your heart rate increases even more because of sympathetic activity or because of epinephrine and norepinephrine. Okay, contractility strength of the heart is just the strength that the heart contracts with. The more contractility, the more your heart contracts. So more contractility is good. This is due to calcium. The more calcium you have, the higher your heart contracts. Frank-Starling mechanism increases your stroke volume, but not through contractility. Contractility is just through calcium. That's directly on the heart. Frank-Starling mechanism is just your heart stretching and pumping out more blood. That doesn't increase, that's not directly contractility. That's just increasing your stroke volume.
Finger mechanism due to greater venous return. Increases in diastolic volume, how much blood enters your left ventricle, which will stretch the ventricles, leading to a more forceful contraction because your sarcomeres stretch more. So that does not have anything to really do with calcium. Although the line separating finger mechanism and the inotropic effect of calcium increasing contractility is a little fuzzy because they work together. I mean, they work indirectly, but one depends on the other. Like, you can't increase your finger mechanism because it causes more contraction unless you increase your calcium. So it's a little iffy. Question 7, define cardiac output. How is it measured? Cardiac output is heart rate times stroke volume. Cardiac output is how much blood is circulating your system every minute. Higher cardiac output is good. Blood leaving the left ventricle every minute. Stomach grace it will increase greatly with exercise because your body senses, your brain senses that your muscles need more blood, so thus your cardiac output will increase. 2 formulas, heart rate times stroke volume, and also the Fick equation, which the Fick equation is mostly to measure VO2, but you can also measure cardiac output from it. It's VO2 equals cardiac output times AV return. Just heart rate times stroke volume. That's about it. And then you can measure your VO2 with a formula, or you can give someone a max VO2 test. Max VO2 test measures your cardiac output and your AV return with tubes and whatnot. Question 8, give mechanism controlling stimulation of the heart rate prior to and during exercise. And I went over this kind of. Your heart beats at 60 to 100 beats per minute because of the SA node, but we all know a lot of people where the heart rate is slower. It's around 40 to 50 beats per minute. And the reason it's slower is because they're in better shape. They're in better shape, so when you get in better shape, your heart stops working as much. So what happens physically is, or physiologically, is your heart stops, or your parasympathetic tone, which connects your brain, medulla oblongata, to your heart through the vagus nerve, which is the main parasympathetic nerve. Through the vagus nerve, it sends more signals or acetylcholine neurotransmitters to your heart, and acetylcholine slows down your heart rate. It tells your heart that it's in better shape, it doesn't have to beat as much, so it slows down your heart rate. And this is good because when you're fit, your heart doesn't have to beat as much. So it slows down your heart rate via acetylcholine. So the main thing to know from that is acetylcholine slows heart rate. Acetylcholine slow, acetylcholine slow. If you want the mechanism, just know acetylcholine slows down your heart rate via the vagus nerve. And that's parasympathetic activity. Then once exercise starts, your vagus nerve starts decreasing, so then your heart rate starts increasing because the acetylcholine isn't there anymore to suppress it. So your heart starts increasing to 100, and then once it gets above 100, and then the sympathetic system takes over, and that's when epinephrine is released now instead of acetylcholine. Epinephrine and norepinephrine, they do the same thing kind of, but they're released, they cause the heart rate to beat even faster and to increase contractility. So they speed up, they get your body ready to fight. It's epinephrine, it's adrenaline, it causes your heart rate to increase. And then once you stop exercising, the opposite happens. When you stop exercising, your heart rate slows. So since epinephrine and norepinephrine speed up your heart rate, it makes sense that when your heart rate slows, you decrease epinephrine and norepinephrine until you reach 100 beats per minute. Then your sympathetic starts taking over. 9, pretty much the same thing. Describe the effects of the parasympathetic and sympathetic nerves. Parasympathetic slows down your heart rate via the vagus nerve via acetylcholine. So you're going to know acetylcholine, vagus nerve, parasympathetic, slows down heart rate. And then the sympathetic, which is epinephrine, norepinephrine, speeds up your heart rate. And really there's no nerve for that, it's just effect. It's just releasing act on your heart. Sympathetic increases your heart rate, increases cardiac contractility, so it causes the heart to work harder, which is good in this case. Question 10, explain the indirect method of measuring blood pressure. What is systolic and diastolic pressure? Blah, blah, blah. What changes occur with exercise? The indirect method to measure blood pressure is with a stethoscope and a cuff. And what that does is you place the cuff right here, and the main artery is your brachial artery. That's the artery we care about. That's like, well, when your blood pumps blood, your brachial artery is the strongest artery. It beats the most. So your brachial artery is right here. You place the cuff right here. You inflate the cuff to a certain pressure, and what this pressure does is depending on your blood pressure. But what this pressure does is once it gets high enough, it occludes your blood flow. So it stops. What that means is it stops blood flow. So it keeps the blood flow up here. It occludes it. which is why if you leave a stethoscope cuff, well, not stethoscope, but you leave a blood pressure cuff on for probably like, if you leave it on probably for 20 seconds and you leave it inflated up to a certain point, you start getting lightheaded and your muscles start, like, you can feel your muscles being occluded from blood flow and start getting all tingly and whatnot. But essentially, you inflate the cuff to a certain pressure, and this pressure, once it reaches high enough, will occlude blood flow, so it'll stop the blood flow. And then you slowly release the pressure, and then you place a little stethoscope on your brachial artery. And then you'll literally be able to hear the blood pulsating through the arteries as the blood slowly is able to move again because you occlude the blood flow. And what these are called is called the Kratkov sounds. And you can literally hear it, and it just sounds like a thud, like a thud. You just hear a thud every time the blood starts moving through your heart. The very first thud you hear is your systolic blood pressure, which is the highest blood pressure. And the very last thud you hear is your diastolic blood pressure. And that's with the 120/80, which is a normal blood pressure, or like 100/60, which is still normal for some if you're in shape, or for if you have hypertension or high blood pressure, 160/890 or something like that. And what that means, the 160 number, what that means is that is how much pressure is on the systolic blood pressure. So if you inflate the cup to 180, it occludes the blood pressure. The blood can't get through that pressure anymore. So that's the indirect method of blood pressure. Now there's other methods, of course, but that's the most common method. Systolic blood pressure, SBP, is the highest blood pressure. That's the pressure when your left ventricle pumps blood throughout the aorta, which is the largest muscle in the body, or the strongest muscle. I'm going to say not the largest muscle. But when it pumps blood throughout the aorta, through the arteries, and that pressure, when it pumps out through the aorta, is the systolic blood pressure. The diastolic blood pressure is the pressure of the heart when it's resting. So it's typically lower, which makes sense because the heart's resting. Why would it be high? And that's usually 120/80. Total peripheral resistance, or TPR, as we explained, is the resistance to blood flow, and this is through vasoconstriction and vasodilation. So when you're not exercising, you have a high TPR because your body doesn't need to lower the resistance to blood flow. Once you start exercising, your TPR decreases as your vessels vasodilate, so more blood can flow through your arteries. Mostly through the diameter of the diameter of the vessels. Okay, now 11, we can go over that. Describe the microcirculation of blood flow through the capillary beds. Now, when you're exercising, we know our brain senses, our cardiovascular control center, the medulla oblongata, senses that we need more blood flow to the muscles. So that's the number one goal: increase blood flow to the muscles, keep the muscles happy. Because as you're exercising more and more and more, your muscles need more and more and more blood, more and more oxygen, which is in the blood. So its number one goal is to vasodilate, to increase the blood flow to these organs, and vasoconstrict. So it vasodilates to increase blood flow. But it also, now the microcirculation of blood, he's referring to the actual little, like the capillaries vasodilate, not the capillaries. The arteries vasodilate, we know that. Arteries vasodilate. But also what happens is the capillaries are a little small tubes. The capillaries also vasodilate, but that is independent of epinephrine and norepinephrine. This is autoregulation. It does this by itself. And what that means is it does this in response to certain molecules of exercise. And these certain molecules, you can either memorize them or you can know that they're results of exercises. Hydrogen ions are one. Hydrogen ions are from lactic acid, so as you exercise, a side effect is lactic acid. It's indefinite, you're going to get lactic acid when you exercise. A side effect is hydrogen ions, so the hydrogen ions tell the body it's exercising. The body's not smart enough to know it's exercising. It depends on outside cues. It depends on increased heart rate, it depends on muscles contracting faster, it depends on the concentration of certain ions, like hydrogen ions, so that's one. Another one is nitric oxide. Nitric oxide is a vasodilator, so it's something that causes the arteries to open up. So nitric oxide, hydrogen ions, a lower pH, which is a side effect of hydrogen ions, bicarbonate ions, a higher PO2 or presence of CO2, because if you have more CO2 in your system, that must mean you're exercising. That must mean you're breathing more. You have more CO2 than you're inhaling. So these control the microcirculation of blood flow. The capillaries dilate in response to these things.
Now, what it looks like is you have your little capillary, everyone's seen the beta capillary where it's like arteries branch into millions of little thingies. Those are the veins. Now, what happens usually on rest, say you only have one of those things open, the other ones are closed by sphincters. So only one is open, so only certain blood flow goes, and only have certain diffusion of nutrients or of blood, of oxygen. Now, during exercise, all of those capillaries, all those sphincters relax, they open in response to hydrogen ions, CO2. What else do we have? Heat. I didn't mention that, but heat obviously is a byproduct of exercise and all that stuff. So they cause all these sphincters to open, and as more sphincters open, more blood flows increase, and as blood flows increase to the capillaries, you get more diffusion of oxygen and whatnot. Now 12 is AVO2 difference in exercise and rest. We've already went over this. AV, the atrial return amount of oxygen is probably around 20, and rest, say your capillaries, your body only takes 5 milliliters of that, and you have 15 left in your veins, so the AV difference is 15. Now at exercise, your body takes more oxygen, so now say your AV difference is 5. I got that backwards. Sorry. You have 20, your body only takes 5, AV difference is 15, so thus your AV difference is 5. Now when you're exercising, your body takes more of that, so now 20, say your venous is 5, so your body took 15. So the AV difference increases with exercise. Now if it increases the more in shape you get, I guess that's another question we'll go over later, but AV difference increases with exercise. As intensity increases, oxygen consumption increases. That makes sense. As you exercise more intensely, you need more oxygen. Question 13, what is the CR center? How and from where is it stimulated, and what does it respond to? This was everything I've been talking about with the cardiovascular control center. The CR center, which is the cardiovascular center, is pretty synonymous with the CVC, which is the cardiovascular control center. Now, the CR is in the medulla oblongata, so that's just saying your brain controls exercise, it controls everything. So your brain controls everything in the cardiovascular center. So now say you're not exercising, so your cardiovascular center it's pretty much telling your body, it's sending little signals through the vagus nerve, parasympathetic system. It's saying acetylcholine, and it's telling your heart rate to slow down, to conserve, to rest. It doesn't have to beat as much, slow down contractility, whatnot. So it's causing it to slow down. And then once you start exercising, your body senses this through different byproducts. So now your cardiovascular control center will tell your heart rate, okay, now let's withdraw acetylcholine because we need our heart rate to increase and we need our contractility to increase in order to supply blood flow to the muscles. So now acetylcholine is taken away. So your vagus tone decreases, your parasympathetic input decreases. So now epinephrine increases, your sympathetic stimulation increases. So now what this does is it speeds up your heart rate, it speeds up your contractility, it causes your heart to work harder, so you pump out more blood. So its goal was to increase blood flow to muscles. And it accomplished that by pumping out more blood and vasodilating also. So your cardiovascular control center did its job. But it also has to control blood pressure. Remember, its two roles are to increase blood flow to the muscles and control blood pressure in perfect harmony. And this is ultimately what stops exercise and whatnot. So you're exercising, you're increasing blood flow. So as you're vasodilating, you're increasing blood flow, but you also have to regulate blood pressure. So it has to vasoconstrict and vasodilate in different parts of the body to regulate your blood pressure. So your cardiovascular control center has this massive job of regulating blood pressure with exercise. But now we think, what is more important with exercise? What is more important to the body, to regulate blood pressure or to increase blood flow to the muscles? To regulate blood pressure, because regulating blood pressure is obviously more important, because if blood pressure gets too high, that's not good. Your body's going to start, we all know what happens with hypertension, the heart starts self-destructing. It's counterproductive if your blood pressure gets too high. Your heart gets weaker and weaker and whatnot. So we want to control blood pressure ultimately. So when you're exercising, say the intensity of exercise is increasing higher and higher and higher. So your cardiovascular control center realizes that the muscles need more and more and more blood. So your heart starts beating faster and faster and faster. You start vasodilating, vasoconstricting everywhere to increase blood flow to muscles. But eventually, your blood pressure starts getting too high. So that's why you stop exercising, and ultimately, that's why your muscles stop contracting. That's why you stop exercising, because your body has chosen to control blood pressure over increasing blood flow to muscles. So ultimately, your body ceases blood flow to muscles by vasoconstricting, causing certain muscles to stop contracting.
causing you to be lightheaded, whatnot, and ultimately controls blood pressure. It conserves blood pressure. So that's the main control of the cardiovascular system, to conserve blood pressure. So during exercise, the cardiovascular control center has to regulate blood pressure and increase blood flow to muscles. Massive increase in blood increases blood pressure, and the cardiovascular control center has to control blood pressure throughout the body, blah, blah, blah. Okay, so response to neural and hormonal. What this means is neural is epinephrine, norepinephrine, acetylcholine. Acetylcholine slows down heart rate. Epinephrine speeds up heart rate. Epinephrine also vasodilates and whatnot. That's neural. Well, neural is mostly parasympathetic and sympathetic. Those are the terms. Hormonal, HOR. Hormonal is responding to hormones, norepinephrine, epinephrine, acetylcholine. There's other hormones that aren't that important, but responding in hormones. So everything in the body happens through hormones and neurons. So that's the neural, parasympathetic, sympathetic, hormonal, epinephrine, norepinephrine, acetylcholine. Now they line up with each other, but they're not the same. If that makes sense. If not, read the guide. But it controls speeding up heart, contracting blood vessels, dilating blood vessels, slowing down heart rate, increasing contractility, all that stuff. Question 14, what are the neurotransmitters? How do they exert their influence on what organs? Now, neurotransmitters are chemical messengers of the body. There's acetylcholine, epinephrine, norepinephrine. They're the main ones. Acetylcholine slows down heart rate through the parasympathetic nerve, slows down everything, it's rest and digest. Epinephrine speeds up everything, it's adrenaline. Epi speeds up everything, it's sympathetic. So that's really all you need to know. Epinephrine speeds up the heart rate, increases heart contractility, contracts blood vessels. So epinephrine's kind of tricky. He'll go over on the, I'm not going to say what it contracts and dilates, that'll be on the third test. But, or if Eddie's teaching right now, I don't know if Eddie's in the class, but I'm sure he gave the PowerPoints. If not, I'll post all the PowerPoints on the page, and that explains everything about what epinephrine does, what acetylcholine does, exact values and everything. So I'll just post that on the page. Hormonal and neural stimuli we went over. Neural is parasympathetic and sympathetic. Hormonal is epinephrine, norepinephrine, and acetylcholine. Okay, now we're switching from the cardiovascular to respiratory. Now I don't know how much you focus on respiratory in your class, but from my experience, from last semester and the previous semester, the whole test was actually respiratory. Respiratory was a big part of the test. So in my study guide, I focus on respiratory because it's very important to know the different terms like tidal volume, IRV, ERV, blah, 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 respiratory reserve, all that good stuff. All these different values like 160, 100, the blood flow to the muscles, all that stuff. So I'm taking time to go over the values since that's probably going to be a focus of the test, even though it's like one question on the study guide. 16, what is the partial pressure of gases, and how does it influence the diffusion of gas in the lungs and at the tissue? Partial pressure of gases, the simplest definition for partial pressure of gases is the pressure of just that gas in a container of air or a sea of air. Now, an easy way to realize that is looking at the composition of air around you. Air around you is made up of nitrogen, oxygen, and many other small molecules that we don't care about. But nitrogen and oxygen, mostly nitrogen. Nitrogen is around 79%, oxygen is around 21%. So what partial pressure is, the partial pressure of oxygen in the air is 160 milligrams of mercury. What that means is the partial pressure of nitrogen is around like 600 milligrams of mercury. Reason being because nitrogen takes much more percentage of the air than oxygen does. So if that makes sense. So oxygen exerts 160 milligrams of mercury because it's only 21%. Nitrogen exerts 600 milligrams of mercury because it's 79%. And you don't have to know those numbers. Partial pressure is found by taking the barometric pressure, which is always 760 milligrams of mercury at sea level, times the percentage of whatever the composition is in the air. Since oxygen is 21% in the air is 21% oxygen, you take 760 times 21% and you get 160 milligrams of mercury. Nitrogen is 79%, so you take 760 milligrams of mercury. Again, the barometric pressure does not change, times 79% nitrogen, and you get 600 milligrams of mercury. So the partial pressure is just the pressure of that specific molecule, independent of every other molecule. but you do need to know 160 milligrams of mercury. So all around us, the partial pressure is 160 milligrams of mercury. Now, what does this mean? Why is this important? You have to know this because pressure or oxygen moves through diffusion. And this is very important because since we breathe in 160 milligrams of mercury, that means our lungs have, or what our lungs have a smaller, less pressure of oxygen. And since everything moves through diffusion, oxygen can diffuse from 160 down to 105-ish in the alveoli sacs. That's what it is. Vital to breathing, everything involving oxygen requires diffusion. So high partial pressure diffuses because of low partial pressure. So you go from high pressure to low pressure. So since you breathe in 160 milligrams of mercury, this high pressure allows 160 milligrams of oxygen to diffuse into the alveolar sacs with 105 milligrams of mercury. And this is important when we start talking about high altitude. But since it's a lower pressure, 160 to 105, oxygen has no problem diffusing down to the 105. And this is in the alveoli sacs. Now, once it's in the alveoli sacs or in the lungs, it diffuses into the bloodstream because 105 in the alveoli sacs, 100 in the bloodstream diffuses into the bloodstream, diffuses down. So now the arterial pressure of oxygen, or the PVaO2, if he writes the little arrow, little things, which I didn't include in the guide, but here will include a lot of terms, and terms are annoying, but PV, pressure, I don't know, he doesn't use P, but PO2 is partial pressure of oxygen. That's 160. Capital PO2. Partial pressure in the alveoli is capital P, capital AO2. Partial pressure, alveoli, 105. P little AO2, which you'll probably see, or if you haven't seen yet, is the partial pressure in the arteries. P little AO2, or the arterial partial pressure. That is around 100 milligrams of mercury. And now PV, P little VO2 is around 40 milligrams of mercury. Now there's 100 milligrams of mercury. That's the partial pressure of oxygen in the arteries. Once it gets to the capillaries, that's when the oxygen diffuses out into the tissues. So in the capillaries, that means whatever the partial pressure is in the organs, it must be lower than 100 because it diffuses out. So now all the oxygen diffuses out into the organs, and now when the blood is returning to the heart, the right atrium of the heart, the partial pressure of oxygen, or the PVO2, is around 40 because most of the oxygen went into the organs. So it's around 40, and it goes back into the lungs, and you diffuse it out into the air. So don't think of how the diffusing out works in the air. Just know the values of 160 in the air. You breathe in. So the capital P O2 is at 160. You breathe it in. It goes into the alveoli. So P capital A O2 is 105. It goes into the arteries. So P little AO2 is 100. Goes through the arteries, diffuses in the capillaries, and it goes back to the veins. So P little VO2, or the venous arterial pressure of oxygen, venous pressure of oxygen, is 40, and then you diffuse it out. And these numbers are important because it's what drives oxygen breathing, diffusion. And now why this is important is altitude. Now you can think of altitude. With altitude, say you take someone at sea level, so the barometric pressure is 760, and then you put someone on top of Mount Everest. Why is it harder for them to breathe? It's harder for them to breathe because the partial pressure of oxygen in the air is much lower. And it's much lower because at sea level, the barometric pressure is 760. But all the way on top of Mount Everest, the barometric pressure is like 300 or something. Now, there's still 21% of oxygen in the air regardless of where you're on Earth. So now, instead of 760 times 21% to give 160, it's 300 times 21%, which I don't know what that equals to. But that's a very small number. It's probably like 100 or 110, I don't know. Now I want to do it on my phone. But it gives you a much smaller number. I don't know if it's 300, but let's say the barometric pressure is 360 on top of Mount Everest. That is equivalent to 75. It's very low. But since it's very low, that means it's very hard for the oxygen to diffuse into the alveoli. The partial pressure on the alveoli does not change. It's still 105, and it's still 100, it's still 105 in the lungs. But since you're breathing in a much smaller amount of oxygen, it's going to be very, very, very hard to breathe. That's why it's very hard to breathe at altitude. Barometric pressure equals everything. And that's actually what the oxygen dissociation curve is and the Bohr effect, which we'll get to. Not really the Bohr effect, but
17 was different respiratory volumes and capacities. I would know these for sure. I would know the numbers because there's not a lot you can ask about respiratory, but he could ask these numbers. The different respiratory, 511. The different respiratory things of volume is the different numbers you have to know. One's capacity for breathing is explained in different terms. So when health professionals explain what is a tidal volume, what is a TV, what is this person's breathing capacity, they're talking about these different numbers. And based on these numbers, if it's higher or lower than what it should be, you can tell someone if they have a respiratory disorder or if they have some disorder going on. So now we're just taking a normal breath. So you're just breathing normally, just a normal breath, whatever, you're just talking. That's called tidal volume, how much air you normally inhale without even thinking about it. And that's around 500 milliliters, let's say milliliters of mercury, but it's 500 milliliters. So every time you breathe without even thinking, you breathe in 500 milliliters of air. But as we know, we can inhale a lot more air than we can normally inhale. So if you forcibly inhale, it's called IRV, or inspiratory reserve capacity. Reserve volume, sorry. Inspiratory reserve volume. So everyone just and rest, they're just like, they inhale a lot more air than they normally can, so that 500 milliliters of mercury, they still inhale that 500, but on top of that, they inhale more. And you have to know the number. The number is 2100 to 3200 milliliters of mercury. So you inhale normally, and now inhale normally is passive. You just passively do that. But your IRV, or your inspiratory reserve volume, is higher because you use your intercostal muscles. And this is what you can change as you get stronger. As your lungs get stronger, as your intercostal muscles get stronger, you can inhale much more air. Because your intercostal muscles are what's forcing you to inhale more air. So, and we all know we can exhale a lot more air than we can normally exhale. So a normal breath, just normal breath. Your IRV, inhale a lot more. Your ERV, you exhale a lot more than you can. So you're just like, so you forcibly exhale more air than you can. This is called ERV, expiratory reserve volume, and this is equal to 1,000 to 1,200 milliliters. Know the numbers. So you can inhale a lot more air using your muscles. You can exhale a lot more air using your muscles. Just like in the heart, where you have in-systolic volume, so no matter how much your heart contracts, you always have blood left in your heart. Well, no matter how much air you exhale, you think you exhaled all the air you possibly can with your expiratory reserve volume, just go, and you think you exhale all the air you can. Well, in reality, you do not exhale all your air. If you exhaled all your air, your lungs will collapse because it has no air to keep it inflated. But you've left some air. Some air is always less stays in your lungs. That's called the residual. It's called residual volume. It's called the residual volume because that's what air is left in your lungs. You would never be able to exhale this residual volume no matter how much you exhale. You always have residual volume, and that's measured at 1,200 milliliters of mercury. So you have your tidal volume, normal breath. That's around 500 milliliters of mercury. Inspiratory reserve volume, IRV. So that's inhaling a lot more air. Use your intercostal muscles, so it's no longer a passive movement. It's active. It takes energy. You're using your muscles now. That's around 2,100 to 3,200 milliliters. And your tidal volume. And then whenever you exhale, you can forcibly exhale a lot more air, and that's called your expiratory reserve volume. That's around 100 to 1,200 milliliters of mercury. And then even when you exhale all your air, you always have air left in your lungs. That's called residual volume, and that's around 1,200 milliliters of mercury. So now these are the volumes. Now we can start doing different capacities with different math. Inspiratory reserve capacity is how much air you can possibly hold in your lungs. So you have your tidal volume, so that's 500 milliliters plus your inspiratory reserve volume. Whatever your inspiratory reserve volume is plus your tidal volume, so it's tidal TV plus IRV equals your IRC, or IC, inspiratory capacity. So it's just your TV plus your IRV. This is how much air you can inhale with a breath. It's the capacity to inhale air. Now your functional residual capacity is how much air you can exhale after a tidal volume. It's the amount of air left in your lungs after a normal tidal volume. So after a normal tidal volume,
Okay, you have your IRV. You still had a lot of air left in your lungs, but you chose not to exhale it. You didn't choose to do your expiratory reserve volume, so you still have a lot of air left in your lungs. So you take your IRV plus your RV, because that's air in your lungs. So whatever air is left in your lungs after a normal tidal volume is your functional residual capacity. Now your vital capacity, people mix up vital capacity with total lung capacity. Your vital capacity is a total amount of exchangeable air. So it's your ERV, no, it's your IRV plus your tidal volume plus your ERV. Now why wouldn't you include residual volume or your RV? Because that's not exchangeable. You can't use that. It doesn't affect it. So your vital capacity is important because your RV doesn't really play a role into that. Now your total lung capacity, or your TLC, is everything. So it's your IRV, your IRV plus your TV plus your ERV plus your residual volume. So it's the total amount of air, regardless whether you can use it or not. Now the very last thing you have to know is dead space. Dead space is air that you cannot do. Now, from anatomy, I'm not going to talk about the anatomy of the lungs and all that stuff with all the different tubes, with the trachea, the bronchioles, all that stuff. But there's so many tubes for oxygen to get from the air to your alveoli that you breathe in 500 milliliters. Yes, that's true. But really only 350 of that is you can actually use it. 150 is lost somewhere in all those tubes. It gets lost. Just like in a maze where you have, like, say you have 10 people going through a maze. Few of them get lost. They lose themselves, they die, they never come back. So you lost them. So that's dead space. They're dead. Just like air, you have 500 milliliters go through your all those tubes, bronchioles, and all that stuff, all those pathways that get to your alveoli, but you lose some of it. That's dead space. You never get it. So in reality, your tidal volume is 500 milliliters of mercury, but it only measures like 350 because you lose 150 of that. If that makes sense. Don't know how much you talked about. Better safe than sorry. I don't know, just learn it all. 18 is, what does exercise have on the oxygen cost of breathing? How does exercise affect breathing? This is very similar to our cardiac output, as we'll see. With exercise, we know we breathe faster and we ventilate faster. Ventilate is a fancy word for breathing. We breathe faster, we all know that. Our ventilation increases. Now, ventilation is just like cardiac output. As you exercise more, your cardiac output increases. With exercise, your ventilation increases, or the amount of air increases. So ventilation equals TV times frequency, or the frequency of breath, or how much you breathe per minute, it's measured in minutes, plus your tidal volume, or your tidal volume is synonymous to stroke volume. So if you think as ventilation being very synonymous to cardiac output, it's much easier. Cardiac output, heart rate times stroke volume. Ventilation, VE equals tidal volume, TV tidal volume times frequency, which frequency is like heart rate. It's measured in beats per minute, well, not beats per minute, breaths per minute. So just think of it as being synonymous. If you know what cardiac output is, if you know the concept, you know ventilation. It's very easy to relate. So obviously we breathe more and more with exercise. Our tidal volume increases with exercise. We inhale more. We all know that with exercise. Now, also the percentages are very similar, just like how stroke volume increases around 40 to 50% and then it plateaus. It's the same thing with tidal volume. Tidal volume increases to around 40 to 50% and then it plateaus. Frequency or heart rate increases exponentially past 50% or 40% of max VO2. Same thing with frequency. Frequency of your breaths per minute increases exponentially past 40 to 50% of VO2. So the respiratory system is a lot like the cardiovascular center. So if you understand the respiratory system, you understand the cardiovascular. I wouldn't say that. Other words, if you understand the cardiovascular system, you understand the respiratory system. They're very similar. What are the expected training effects on VE? VE is ventilation. It's the word hemoglobin and blood volume. Ventilation. Okay. Ventilation, unlike cardiac output. Cardiac output you can increase with exercise, we all know that. But ventilation is different. You can't really increase ventilation with exercise, with training. So you take a fit athlete, you work them to the maximal. You take an unfit athlete, work them to the maximal. Most likely the ventilation is the same. Reason being because if you look at a formula, frequency times tidal volume, you can't really change your frequency of breath. You can only breathe so many times per minute. I mean, go with what he says, but with training, ventilation doesn't really increase. Hemoglobin doesn't really increase with training. Your body does not adapt and make more hemoglobin. Of course, you can increase hemoglobin. You can increase hemoglobin illegally with drugs, because the more hemoglobin you have, if you remember, hemoglobin carries oxygen. So the more hemoglobin you have, the more oxygen you can carry. You can increase this illegally, but you can't really increase it with training. You can increase it a little bit with training, but it's not really noticeable. Of course, you can lose hemoglobin with diet by not having enough iron, or with diseases like sickle cell anemia. And also, men have more hemoglobin than women. Men are around like 16, 17. Women are around, say, 13. This is why if you make all factors equal, so say they're in the same fitness, they have the same enzymes, they have the same lactic threshold, which you didn't go over, but they have the same lactic threshold, they have the same whatever. They have the same amount of training. They're very similar in everything else. Men will always be faster than women because they have more hemoglobin. So no amount of training can cause a woman to be faster than men if everything else is equal. I'm not saying women are not faster than men. There's a lot of women that are faster than men, but if training is equal, if they have the same exact lactic threshold, they have the same enzyme amount, they have the same training, if everything is equal, men will always be faster because they have more hemoglobin. They can't really do anything about that. Understand the importance of the oxygen. The Bohr effect. This is a very important concept. He loves the Bohr effect. Everyone loves the Bohr effect, actually. Like on the MCATs, like every single question is the Bohr effect. What affects the Bohr effect? What is the Bohr effect? The Bohr effect, you have to look at a graph to understand it, but if you understand the partial pressures of oxygen and how it's like 1/6, I mean, it's like 100 in the veins when you're exercising and whatnot, and you have to look at the graph to understand it. So the partial pressure is like this. It's a sigmoidal curve. We're down a little bit. It's a sigmoidal curve, and then there's like the partial pressure differences, like PaO2, P little AO2, and then there's percentages. And the percentages on this side, also on this side, are the same, but the percentages are how much oxygen is left on the hemoglobin. So a high percentage is good, but a high percentage is not good when it unloads. So you want more oxygen to unload. You want to increase oxygen unloading, if that makes sense. So take rest. Say you're resting. Our partial pressure of oxygen in the veins is around 40 milligrams of mercury. I have to look at, yeah, it's around 40 milligrams of mercury. So I guess we're looking at the veins. So the partial pressure in the veins is around 40. So if you look at the sigmoidal curve, just download a picture or whatnot, you probably have a picture, but it's like 40 milligrams of mercury is right here. 40 milligrams of mercury is on top of the sigmoidal curve, or yeah, it's on top of the sigmoidal curve. So what this means is if you line this up, this shows that hemoglobin is around 90% saturated, 90 to 100% saturated. So what that means is from 40 milligrams of mercury to 100 milligrams of mercury, since it's a sigmoidal curve, 40 milligrams of mercury does not really have a big difference with 100 milligrams of mercury. It's still 100% saturated. But as you start exercising, what's 40 milligrams of mercury? And that 40 milligrams of mercury is still, okay, I said it all wrong. Sorry. Okay, so now we'll go back to the beginning. But okay, so partial pressure of oxygen in the arteries is 100 milligrams of mercury. Looking at the sigmoidal curve, 100 milligrams of mercury lines up with around almost 100% saturated. That's good. That's what we expect. When what that means is the blood in our arteries is around 100% saturated with oxygen, or the hemoglobin is around 100% saturated with oxygen. That's what we expect. But when we're resting, then the partial pressure is 40 in the veins, if you remember. Now, if you look at the sigmoidal curve, what that shows is 40 is around 60% saturated with oxygen. So that shows you that when we're resting, our body only unloads around 40%. There's still around 60% oxygen attached to the hemoglobin. So when we're exercising, we want more of this oxygen. So how do we get more of this oxygen out of our hemoglobin? How do we extract more of it? This relates to the AV return. How do we extract more oxygen? Well, remember, our body responds to everything with exercise, to different cues, like a lower pH, more hydrogen ions, more heat, a higher body temperature, which is the same as more heat. So this is what cues the body that's exercising. And that is actually what causes this curve. These factors facilitate oxygen unloading. So you take the curve, you have your 100 and you have your 40. So you want to shift the curve to the right. If you shift the curve to the right, that means now 40 milligrams of mercury is now probably like 20% saturated. So that means you extracted much more oxygen. So you want to shift the curve to the right. And this is what happens when you exercise. Now, how do you shift the curve to the right? Different factors will shift the curve to the right, and these are very important to know. A higher PO2, PCO2. What this means is you have more CO2 in your blood. If you have more CO2 in your blood, that means you must be exercising. You must be inhaling a lot more than you're exhaling, because CO2 is a byproduct of whatever, you exhale CO2. So if you're inhaling a lot more than you're exhaling, then you have more CO2 in your system. So if you have a lot of CO2, it's going to shift the curve to the right. If you have a very low pH, so your body's very acidic, a very low pH and a very high hydrogen ion concentration go hand in hand. A very high hydrogen concentration equals a low pH. High hydrogen concentration means you have a lot of lactic acid. Low pH is a side effect of it. You have a lot of lactic acid. This is a side effect of exercise. Increased body temperature. When you exercise, we all know your body gets hotter. It increases body temperature. Oh no. It increases body temperatures when you start exercising. So all these things shift the curve to the right. Thus, they facilitate oxygen unloading. That's a positive effect. These tell the body it's exercising. So just think, when my body's exercising, what tells it? What happens when it exercises? Well, it increases body temperature. I'm gonna have more CO2 in my blood. I'm gonna be more acidic. I'm gonna have a lower pH and a higher hydrogen ion concentration. So you can just think of the concepts that happen when you start exercising, and these will shift the curve to the right. And this is positive because it causes oxygen unloading. That's called the Bohr effect, or the oxygen dissociation curve. That's what the curve is called. Last question is, how can a VO2 difference be determined from the oxygen dissociation curve? Just look at the curve. You have your normal curve right here, and then you have your Bohr effect curve when the curve shifted. You just draw all those things and you just do the difference. It's hard to do without pictures. Question 1 is on VO2. I don't know if he went over this in his class, but in summer he went over this, so I'm going to go over it just in case. So to clarify anything, question 1 on aerobic capacity is, what is VO2? Explain the concept. What is VO2 measure? How do you know if a subject has reached VO2? Because this will probably be a question. Like, how do you know it's reached? How do you know you're in your VO2? Well, VO2 is the maximum capacity for the body to use oxygen. A higher VO2 means your body can use more oxygen per minute. It's measured in milliliters per kilograms per minute. So the more, like say your VO2 is 40 versus 70. 70 means you can use 30 more milliliters of oxygen per kilogram of your body weight per minute. So that's more effective, obviously. More oxygen is good. So more oxygen, higher VO2, you're better at exercising. You're better, or not, you're better at cardiovascular exercise. VO2 is the main thing all cardiac units look at. They look at your VO2 for your fitness. If your VO2 is very, very, very low, you're not doing that good. If it's very high, you're very fit and you're doing good. Now, it's proportional to exercise intensity, obviously. If we exercise harder, our VO2 is going to increase because we're going to use more oxygen. Now, criteria determine if a subject has reached it. To calculate your VO2, you have to get on a treadmill, or you have to do a maximal VO2 test or a submax test. A maximal VO2 test is when they hook you up on a treadmill with a bunch of tubes and you exhale through the tubes, and they can measure how much CO2 you exhale, they can measure how much oxygen you inhale, and they can do a bunch of formulas and figure out your VO2. Now, the criteria to reach your true VO2 max is you have to pass out. There's no other way. Because everyone's body, you can always exercise longer than you want to. So if you want to stop exercising, you can always probably go another 2 minutes. If you really force yourself, you can go another 2 minutes. So a true VO2 is not reached until you pass out. So if you do a VO2 test and you have not passed out, that is not your true VO2. Until you pass out, you reach your VO2, your VO2 max. Now, if you voluntarily choose to stop a VO2 test because it's getting very tough and you want to stop, that's not your true VO2. They call that your peak VO2. So say like I'm doing a VO2 test and it's very hard for me and it gets really hard at 60 and I want to stop. If I stop right there, my peak VO2 will be 60, but my VO2 max could have been 63, but I didn't know because I didn't stop. So there's 2 ways to determine if you reach your VO2 max. One way is if you pass out. Obviously, if you pass out, you reach your VO2 max. Another way is if exercise intensity, if they keep increasing the intensity, but your VO2 max is not increasing. So how VO2 max test works is they put you on a treadmill. They usually increase the speed up to a certain point, and then they start increasing the elevation. We all know when you're running uphill, it's a lot harder. So they increase the elevation, say, to 1%. You can say your VO2 keeps increasing even more. So you have obviously not reached your VO2 max. They increase it to 2%. Exercise hard, your VO2 keeps increasing, but now they increase it to 3%. Your VO2 max, your VO2 plateaus, say at 65, and then they increase it to, but you can still keep exercising. So then they increase it to 4%. The exercise intensity is obviously much harder because it's 4% now, but your VO2 is still at 65. So that's an indication you reached your VO2 max, and now you're depending on anaerobic glycolysis, the whole anaerobic stuff that we went over in the first test. So when your VO2 stops, increasing. When it's increasing intensity, you reach your VO2 max. When you pass out, you reach your VO2 max. Your peak VO2 is when you voluntarily choose to stop. What are some factors that can affect VO2? Well, since VO2 is cardiac output times AV difference, any factor that's going to increase your stroke volume and heart rate is going to increase your VO2. Obviously, training. Training will increase your VO2. Blah, blah, blah. Activity, running will achieve the highest VO2 if the asses. That's, if you think about it, running uses, VO2 is a measure of oxygen consumption in the body. Running uses the most muscle, so it's going to use the most oxygen. Even if you go all out in running or if you go all out in cycling, running takes more oxygen. So you're going to have a higher VO2 in running if you take the same individual in the same, they go the same intensity. The amount of mitochondria. Mitochondria increases how much oxygen your body uses. So if you have more mitochondria, you're going to use more oxygen, more higher VO2. Heredity, gender. Males have more. Everyone knows males have higher VO2, unfortunately, because they have a lot more hemoglobin and they have more muscle mass. It's just genetics. Some factors: VO2 improvement through exercise is obviously increasing your cardiac output. All the mechanisms that increase your cardiac output were explained already. How does the concept of specificity apply when talking about VO2 max? Here include mode of exercise, subject fitness level, and different types of equipment that might use to measure VO2 max. Well, this is essentially asking what mode of exercise specificity will increase. How does that apply when talking about VO2? That's the same when if you're running, or if you're biking, or if you're doing a step test, how would that affect your VO2? Well, running, I already said, running is the best test to measure VO2 because it uses the most muscle. Cycling is still good, but running is the best because it uses the most muscle. So running is usually used to measure VO2. Other tests that are not maximal and treadmill. Maximal is using tubes and you're running to exhaustion. It measures your max VO2. Other tests are called submaximal tests. You will do these in exercise testing. It's on the cyclogometer usually. That's when you're cycling and you don't go to max. You reach a submax certain percentage of your heart rate. I think it's 85% of your heart rate. So you exercise at 85% of your heart rate and then you stop. And then they use a little formula and graph paper to estimate your VO2 max. Estimate, so it's not that accurate. They do this because they do this with the assumption that your VO2 increases linearly with your heart rate, and this is not true. Once you get to exercise testing, you'll find that it's not true. Your VO2 does not increase linearly with your heart rate. And the reason why this isn't true also is because they use that formula 220 minus your age, and 220 minus your age is an estimate for your max heart rate. So this can skew the whole result. So the end result is a submax test is not as accurate as a maximal test because they're estimating your VO2. What factors account for the gender differences in VO2 max? Mostly women have less hemoglobin, they have less muscle mass, so thus they'll ultimately have a lower VO2. A woman will never, if you take, I think the highest VO2 a woman's ever achieved is like 60. The highest VO2 a man's ever achieved is like 95. A woman will never achieve a higher VO2 than a man. All factors equal. Trains equal, whatever. Now you can take a fit girl, you can take a fit woman in track and take an unfit man, and the woman will have a higher VO2 most likely. But all factors equal, a woman would never have a higher VO2 than a man, just because they have less hemoglobin and less muscle mass. Now, I included more on this guide on the training principles for aerobic exercise. I'm not going to go over that. Oh, actually, there's a lot on this guide, actually. Hello? Yes. All right. All right, yeah, I'll text them. Yes. Yes. Gambling. I'm not. I'm actually making a video right now on exercise physiology, and I'm talking to you in the video, and I'm drinking a verve. All right, definitely. Oh no. Oh no. Okay, got it. Bye. Bye bye. Yes, that craps. Yeah, so the rest of my study guide goes over training principles for aerobic exercise and coronary heart disease. Coronary heart disease is gone over on the fourth test. I know that for sure. I don't know why I included it on this guide because somewhere he did something weird and only did 3 tests instead of 4. So it's shorter, obviously. Train out principles for aerobic exercise. I don't think he went over, but if he did, it's on the study guide. And yeah, it's also on that free study guide. I'm sure everyone downloaded already, which is my study guide mostly. So it's all there. So that's about it.